All right, we're all good to go. Sorry all about
Great.
that.
That's okay. That's okay. These things happen. So why we operate on things like choroncatatus media is this is a nice view of a CT scan. And with CAT scans, I'm looking for bone more than anything else. And how is the bone? Is it destroyed? Is it affected? Brain is here. This is what's called a coronal view. And then you see all this gray tissue. And that gray tissue in the ear is something we don't want to see. Typically, the way our temporal bone is designed, we should be having air all throughout here. This is the facial nerve here, superior semicircular canal, lateral canal. This is where the stapes would be. This is called the oval window. So all of this is part of its cholesteatoma, part of its granulation tissue, a reaction to cholesteatoma, part of its pus and infection. And you can see if we don't treat this, the disease can get into the inner ear. And because the inner ear is connected to the brain, you can then get life-threatening problems such as brain abscess and meningitis. So the goal when we treat infections are, sometimes all we need is antibiotics, depending on what's going on. But other times we operate, and this is one of the things we're trying to avoid. This is a patient of mine from years ago. This is an MRI scan. And this is a coronal view. This shows a temporal lobe abscess. This is a side view. I don't see these as often as I used to, but I still probably see this every once a year, maybe. And so this is why if someone's having a problem with their ears and it's draining and it's foul smelling, if there's pus, all those kinds of things, you need to get it checked out by an otolaryngologist. And my subspecialty is called otology neurotology because I deal with things like this when they do get into the brain and cause life-threatening reaction. Now, behind the ear is what's called your mastoid, okay? And a healthy mastoid should be like your cheek sinuses, your maxillary sinuses, which means healthy sinuses, healthy ear should have a lot of air in them, all right? So when I operate on the ear, I tell people my goal is to make the ear clean, safe, and dry. I'm trying to prevent it from getting pus. I don't want, imagine, by the way, I've had kids who are in junior high, kids are in high school, and that's a tough age for a lot of youngsters to have foul smelling discharge come out of their ears. And it's very embarrassing for them. And they have kids that are in class with them that make fun of them. So my goal is to take care of those things. And this is a picture of a patient who had a cholesteatoma. You can see this is filling the mastoid cavity, the area behind the ear. Now, how I approach disease depends on where it's located. And sometimes I'll do what's called a mastoidectomy just so I can clean out disease. Other times I'll do it for things like cochlear implants or skull-based cases, tumors of the skull that are different than cholesteatomas. So one of the challenges I face is for people who get a lot of ear infections, the way God designs our skull base, if you look, there's the nose, eustachian tube at the back of the nose, connects to the ear. And that's why when you guys are flying, if you feel like your ears are plugged, you'll kind of try to pop your eardrum. You're trying to put air through the eustachian tube. The problem, a lot of these ear infections are actually due to eustachian tube problems. So one of our goals is, yeah, I can fix the ear disease, but what if we also try to improve the eustachian tube itself so you have fewer ear infections? So there's actually procedures such as what's called eustachian tuboplasty, where you put a balloon into the eustachian tube to try to widen it. We'll treat people who have reflux. You think about antacids and Prilosec to treat reflux, things like that. Some of those reflux situations can cause trauma, actually. Some of the acid can affect the eustachian tubes, and that can happen both kids and adults. One of my concerns is smoking of any substances. I think vaping, tobacco, cigarettes. And my concern is now, as we're seeing more states say okay to marijuana, I think that we're going to start seeing a higher chance of eustachian tube dysfunction and ear disease, because it turns out smokes affects the little cilia, the hair cells in the ear. And so my concern is we're going to start seeing maybe a rise again of ear disease. Treating allergies, treating adenoids, and then how you approach the middle ear. So most people don't know the middle ear, where the three ear bones are, is connected to the mastoid. And sometimes how I address those two things may help in the long run reduce the chance of ear disease coming back. So there's so many different types of surgeries that I can do, and I want to show you cholesteatoma. A cholesteatoma is not a cholesteatoma, meaning no two patients are alike. So you can see a tiny little cholesteatoma here. That's very small. And for something this small, I can actually go through the ear canal, lift up the eardrum, and get that little cholesteatoma. Or you can see this is a massive cholesteatoma that was sitting in the mastoid, and it's hard to tell the size, but this is almost half of your thumb in size. So very big difference between the two. And that's very important because I tell my patients, I tell residents, fellows, I'm very blessed to train a lot of good, bright young people, that you've got to figure out what these different options are to attack the ear disease, and that it's not a one size fits all. And then we're also doing different technologies. So I usually use the microscope to take care of ear disease, but more and more people are using these what's called endoscopes, and they're tiny little tools. And sometimes you can use both of them together to help eradicate ear disease. And at the end, I've got a video that I can show you of how I do some of my ear surgery. So the canal wall up mastoidectomy is a very interesting approach, but basically what I do with that is I work on the mastoid, clean out the infection, clean out the cholesteatoma from behind, and then I leave the canal. So if you actually put your finger in your ear, there's a separation of bone between the ear and the mastoid. And so the goal with the canal wall up mastoidectomy is make the ear look very similar to patients before surgery and after surgery. So it's very similar. Patients then, can they use hearing aids? They can still get their ear wet eventually after surgery. All of these things are things that I think about. Now, there's something called the canal wall down mastoidectomy, and it's interesting. If we were all in a room together, one of the things I do is I'll have people raise their hands. And it's fascinating. I usually see a few people in a room that actually have had ear surgery. The canal wall down mastoidectomy is over 100 years old. It's considered the gold standard. But as you can see, here's a picture of a patient who had a canal wall down mastoidectomy. The appearance of the ear has changed. And then the middle ear, where the three ear bones were, and the mastoid, that area is one big cavity. And for people like Michael or me who have short hair, especially for my male patients, this is often a big problem. They don't like it because it looks funny. They don't like someone looking at them cosmetically, having altered appearance. The other problem is when you alter the anatomy, patients can get dizzy when they swim with this because you don't have the normal protection anatomy. You have to have different types of hearing aids fitted. So if you take a step back, some of this can be very technical, especially for an audience that's just learning about healthcare and medicine. If you look at how the mastectomy has been done over the years, I use an example with my patients of things like mastectomy for breast cancer. Early on, the idea was remove all the breast tissue if you had breast cancer. Well, that's often very disfiguring to a woman. And to say, okay, how do we try to take care of a cancer, but not be so aggressive? Let's maintain more of the natural anatomy. That's our goal with ear disease as well. That on the one hand, we want to treat the problem, but we don't want to hurt the patient too much. This is a great quote. I love reading old literature. So for those of you, as you get into medicine, I think what's amazing about the US is we're so good about looking at the coolest new treatment. But I love reading old literature because these are docs like Tumarkin wrote back in the British journal Lancet in 1948, this quote. And it's fascinating because here's a person who operated at a time when there wasn't a CT scan, anesthesia wasn't advanced, surgical tools weren't advanced. And he said, radical mastectomy, that canal wall down approach, is one of the most unsatisfactory operations in surgery. Before the operation, the patient is more or less deaf and has a troublesome otorrhea. After the operation, he finds himself just as deaf, if not deafer, and only too often, the discharge continues unabated. Patients may well ask, what is the justification for such a serious operation? So if you go back, we're getting close, it's about 75 years since this article or this statement was published. Back then, it was very much an idea of, I'm the physician, I'm the surgeon, I'm going to tell you what needs to be done, and you just accept it. And clearly, there's much more of a give and take in society. And how I approach each one of my patients is different, because I truly still have some of my patients in their 60s, 70s, or 80s, patients who are often in the Medicare population, and they'll say, okay, Dr. Samy, whatever you tell me, I'll do. Whereas someone who's in their 20s or 30s is much more going to say, okay, well, listen, I looked it up on the internet, and this is the stuff that I read. What do you think about it? And I actually welcome that. I love it when my patients educate themselves, because some of these things are so complex. Some of the things I deal with, that the more you know ahead of time, the better. The more you educate yourself and come in and write down on your iPad or on a piece of paper all the questions you ask. I love it. That's a great way to educate yourself. It empowers the patients. So Michael said to me over the weekend, let's talk about some cases, Dr. Samy. Let's get the audience involved. So these are actually real cases. These are patients of mine. And some of these are it teaches you, I don't care how many years you've been doing this. It's 23 years this year since I've been doing neurotology, skull-based surgery. And some of these are very humbling cases for me. So a 43-year-old gentleman, very nice man, who came to University of Cincinnati ER, and he had 10 out of 10 severe ear pain. He's a gentleman who's a truck driver. He's from California, if I remember correctly, San Diego area. And you have to remember, I actually tell my residents and fellows, I need to know when you're presenting the patient to me, I need to know what makes that 43-year-old different than someone else. Right. So a 43-year-old truck driver, if you know anything about truck drivers, they don't make money unless they're actually on the road. So this is a gentleman who for 15 years would show up at ERs because he had severe pain. He'd get antibiotics, he'd get eardrops, he'd get pain reliever, and he'll do well for a while. And then the problem recurs again every 3 to 6 months. So my fellow happened to see him in the ER, and a CT scan and clinical exam showed a cholesteatoma, chronic otitis media with a cholesteatoma. And we ended up admitting him. And thank God my fellow admitted him, because he said to me, hey, Dr. Samy, it's about 2 a.m. when he called me. He goes, I think we need to get this gentleman admitted. I'm really worried about him. And I'm so happy he did, because within the next 24 hours, the gentleman developed nausea and vomiting. And that's always a bad sign. If you have nausea, vomiting, that tells me something is going on intracranially. And then he also had trouble with bright lights. And that's often something that we see with meningitis. So we had MRI scan done, lumbar puncture done, and we're worried about meningitis and an abscess around the brain. What's amazing to me is, so this is a view of the CT scan, and this is an axial CT scan. These are the eyeballs. Remember I said to you earlier that the sinuses should be very similar to your ears. So his sinuses look nice and healthy. All this black is air, white is bone. And the right side should actually have a lot more air than this. There's a little bit of air on the right ear that tells me he has had a lot of ear infections in the past. But that doesn't concern me so much because I still see air today. But look on the left side, there's gray tissue there, gray tissue in the middle ear, and these are connected. So that tells me, and CT scans are not that bright. This is where you as a clinician have to look at the patient and say, does the CT scan, confirm what I'm thinking? And so my fellow, Dr. Neil Showman, he's in Canada, he's at Dalhousie University. He was spot on. He said, hey, Dr. Samy, I think this is a cholesteatoma. What's amazing to me is that gentleman went from this picture to within the next 24 hours, he clotted off one of the main veins in the head. And I had to urgently take him to the operating room that weekend. And all that bone had been destroyed by infection. The sigmoid sinus vein was completely clotted off. If he had not had urgent treatment, this is a gentleman who would have passed away. And we don't think so much about that compared to, if you look back, penicillin, sulfa was invented, I think, 1937. Penicillin, I think, in 40s, 41, 44, something like that. And so prior to that, hospitals were full of adults and kids with these bad ear infections who could have passed away. The worry is the World Health Organization says by the year 2050, we may have up to 10 million people dying a year in the world because of super infections, antibiotic resistant bugs again. So that's a concern for us as time goes on, that all the infections that we used to see that we thought we'd taken care of and treated, that due to overuse of antibiotics worldwide, that we may now get some of these infections coming back. Let's hope and pray that doesn't happen. So another case, this is a gentleman, 41-year-old, came to me back in 2010. A local otolaryngologist sent him to me. We had to wait about a year, 18 months until his insurance issues were taken care of. He had left-sided hearing loss. So when you look at ear disease, the number one symptom I'll typically see is patients who have hearing loss. And that's a challenge because hearing loss can be due to wax. Hearing loss can be due to a hole in the eardrum. Hearing loss can be due to aging, noise exposure, things like that. So you had all these other symptoms from discharge to the ear to fullness and pressure in the ear to ear pain, headache. He's had problems since childhood. He has a history of anxiety disorder, tobacco use. He's had multiple sets of tubes, tonsillectomy, adenoidectomy, and then 2 prior mastectomies. So when a patient comes in, even before I touch them, I try to get a very detailed history, past medical history, all those things, because then I can understand more about them. No medical allergies at all, and no medications that he's been on, and his wife is a nurse. So he came in to see me, looked at his head and neck, right ear looks great. And then he had, many of you may have seen those tuning forks. We use them to check hearing. They look like what's a tuning fork, and the people, when they tune a piano, that's very similar to what it looks like. And I use a microscope to look at the left ear. He had cholesteatoma in the middle ear space, and he had signs of his prior mastectomy procedure. Now, this is really good. If another take-home message for all of you, I would love to see all of you get a hearing test every 1 to 2 years for the rest of your life. And one of the reasons I say that is we're finding out a lot more about untreated hearing loss. So hearing loss is actually the #1 birth defect. Many of you may or may not know that. And then it's also increases with age to where like something like 80% of people by the time they're 80 have significant hearing loss. So many of you, if you don't have hearing loss, maybe your parents do, or if they don't, maybe your grandparents do. So it increases as we all get older. So there are 2 parts to a hearing test that are incredibly important. One part is the tones, right? So these circles represent the right ear. The better you're hearing, the higher up on the graph it goes. The worse the hearing is, the farther down the graph it goes. So his left ear is way down here. So he's got a lot of hearing loss on the left side compared to the right side. But that's only one part of the hearing test, because we don't just hear in tones. We actually hear complex sounds. Whether you're hearing my voice, it's not just one tone, it's not monotone. Or if you're hearing something like Beethoven's Fifth Symphony. I'm a huge classical music fan, and the complexity of the symphonies is unbelievable. So these numbers are important, 100%, 100%. That means that this gentleman can actually, as long as things are played loud enough for him, he can actually understand the sound. And that's very important, because I have some patients who come in who, maybe they're hearing only at 20%. They'll say to me, "Hey, Dr. Samy, I can hear sound. It just sounds like a broken speaker. I can't use a telephone on that side anymore." So that's why this is also very, very important to me. So CT scan was done, and right ear, this is as if he's looking directly at us. This is what's called a coronal scan. And so you can see the right ear looks pretty darn good. And there's the gray tissue on the left side there. And just another image there. These are the axial cuts. So once again, here's the sinuses. He's got a little bit of sinus disease. And some of these patients may or may not complain of any sinus symptoms. Maybe he's got some discharge from his nose, some pain or pressure. But if you look, he has a little bit of air there, not as much as I'd like to see. That tells me he's had old ear infections. And all this gray tissue confirms what I'm concerned about, that he's got cholesteatoma and chronic otitis media in his left ear. So initial plan, when I first meet patients, unless it's a life-threatening disease like the first gentleman where I said, I got to go to the operating room, I got to take care of this, and otherwise this person's going to lose his life. A lot of times with my patients, I want to make sure that I don't overwhelm them. I'll give them information, I'll give them handouts, I'll give them pamphlets, I'll have them. I love it when they come in with their husband or wife or family member, friend, someone having an extra set of ears, no pun intended, have an extra set of ears there is very good, because I think you as a patient, you always have to put yourself in the patient's shoes. Sometimes this stuff is overwhelming. And the moment someone says to you, "Hey, you have a tumor in your ear," now you're scared. And maybe you're not listening well to me. And I always give patients my what's called after visit summary. It's printed out. Now Epic has a phenomenal digital option. So you literally can pull out your iPhone and you have access to Epic My Chart on your iPhone. And so if you forget what I said, you should be able to look at my note and it'll say, okay, this gentleman has a left recurrent cholesteatoma. I'll put him on dry ear precautions, which means that whenever he showers or bathes, put cotton ball Vaseline in his ear. I want 0 humidity in his ear. There's certain bacteria that actually turn out to grow well in a moist environment. So my goal is to stop that discharge. What makes cholesteatoma so dangerous is not only are they these benign tumors that grow over time, but they're actually surrounded by pus and infection. And that's why they're super dangerous as well. I put some powder in his ears to dry up his ears, and I used ear drops as needed. My plan was to do the mastectomy surgery on the left side. And so what I found when I got in there, this is the ear, it's the left ear. What you can't see well is the front part of the ear, but it's pulled forward, it's flipped forward. This is the sigmoid sinus, one of the main veins in the head. This is the size of old ear infection. And what I didn't realize till I got in there was this infection had exposed some of his brain tissue. So this is called an encephalocele. And so a lot of times you plan as best as you can as a surgeon before you go to the operating room. This is my plan. But you also have to realize, oh, if I find problem X, Y, or Z, I can't lose my cool. I've got to take care of this patient and fix it, because if I don't take care of this hole, this infection will continue and cause a brain abscess or meningitis. And this is a nice view of approximately the size of the defect there. It's a little bit over a centimeter. And then I tried to use some tissue to repair that, but there's brain fluid leakage that was still occurring. So when I see things like that occur, I use fat from the belly, and I'll use that to seal off the defect, to seal off the hole. And so that's what I did with this gentleman. And so I ended up closing off his eustachian tube, closed off his ear canal. And because I had not planned this ahead of time, went to his wife, talked to her, said, this is what I'm doing. And she, as an RN, she was very understanding, and kept her in the ICU for one night to make sure there's no sign of seizure or brain injury, anything concerns. And he went home on day 3. And then I'll do what's called an implantable device in the future for his hearing loss. And then after I have cases like that, when I'm surprised by what I find, I take a step back and say, okay, what exactly happened? And by the way, this is the post-operative scan. This is the fat that I placed into the ear here. You can see that tissue there, and then this way as well. And I found out that one of the images that I missed, so this scan here, I thought that was all infection. This is what's called a sagittal view. So instead of being from the front, like a coronal view, it's from the side. So what this shows is this is his jaw joint, okay? Front part of the skull's here, back part of the skull's there. Here's the hole. That's where actually brain tissue was coming down into the ear, and I didn't notice that. So I missed this image. And it tells you this is where the attention to detail and work ethic really comes about, that you as a physician or surgeon have to take ownership of your patients. You're accountable, and you have to say, you know what? This is what I need to do ahead of time to reduce the chance of problems. I'm actually also very impressed by my patients. 99% of patients are outstanding and phenomenal. And the more honest you are with people, the more transparent you are with people. And I just said, hey, I'm sorry, this is what happened. I was not expecting that. They're very understanding. They just want to know, okay, are you there for them? Did you take care of the problem? Now, if I had known ahead of time, how would I have handled the problem differently? Well, sometimes what I'll do is I'll actually not only work through the ear, but I'll work around the skull and do what's called a middle fossa approach, where I actually, this is a patient who had encephalocele brain tissue, this brain tissue here, hanging down to the ear. This brain tissue can cause seizures, can cause brain fluid leak, can cause meningitis. And sometimes what I'll do an approach where I go from above, elevate the temporal lobe of the brain, and then I'll fix the hole here and put fat into the mastoid cavity as well. Final case that I have is an 8-year-old, and talk about how different. I love operating on kids. The youngest person I've ever operated is on a 6-month-old. The oldest person I've ever operated on is a patient's 102, and every age in between. So how I approach each problem is very different. And for an 8-year-old, not only do you have to get buy-in from the parents, they need to know what's going on. You have to build that rapport and trust with kids, because kids are incredibly honest. And if they don't like you, they will tell you, and they will not want you touching them. And so I never rush the exam with kids. I will sit there, and I think it also helps because I'm a dad, right? My wife and I have twin daughters who are 14, and I understand as the girls have grown up, especially since one of my girls was very scared about someone checking her ears. So this young man has had 2 sets of tubes. At the second surgery, the outside doctor found a cholesteatoma, that skin cyst in the middle ear. This kid hates it when there's an ear exam done. He likes to swim. He's got mild hearing loss. And so basically he had a lot of cholesteatoma based off the CT scan in the middle ear space surrounding the ear bones. And so there's a lot of issues here. Everything from how do I make it so I make his ear clean, safe, and dry. I want him to get him back in the swimming pool. If his hearing loss, I'll want him to use a hearing aid, especially for kids. We're finding out that if kids have hearing loss, even if the other ear is fine, if they have hearing loss of one ear, those kids do not do as well in school. So they have trouble advancing. And if you don't do well in school, imagine if Michael said to me, "Hey, Dr. Samy, I want to be a skull-based surgeon someday." Well, the road is very long. You have to do a great job in high school. You got to do a great job in undergrad. You got to do a great job in med school. Then it's 5 years residency and then 2 years fellowship. And at every stage in the game, you got to be a straight A student. Because if you don't get to that level. And the problem for someone like this, if he doesn't hear well, he may not get great grades. So it's very important at a young age you think about things like that. And so this is his CT scan. This is the axial view. This is the sigmoid sinus, carotid artery, jaw joint, jugular bulb, and then his cholesteatoma is right here, this gray tissue. And this is that coronal view, as if he's looking directly at us. You can see how well aerated. This is also the air in his ear. That looks great, but that's where his cholesteatoma was. And so one of the things is that if I said to you that that type of mastectomy that was originally done 100 years ago is the gold standard, we're realizing there's a lot of challenges. And we as physicians and surgeons have always tried to figure out how do we push the envelope to do a better job in taking care of ear problems, taking care of our patients. And so there's something called a canal wall reconstruction mastectomy, where we actually use a saw blade, and that saw blade you can actually use that to cut the bone out that separates the ear canal from the mastoid. And so after we take that bone out, sometimes we'll use cartilage to reconstruct. So just like a lot of things, I have one of my good colleagues does a lot of head and neck cancer surgery. And if he has someone who unfortunately has, let's say, a bad cancer of their tongue from using dip as an example, right? That person unfortunately may lose part of the tongue. And if it's an advanced cancer, may lose part of the jaw. Well, we all look at each other's faces all the time. A lot of communication is nonverbal. A lot of these patients, understandably, when their anatomy is altered, can feel very down. They get depressed. And so my buddy will use skin and bone from other parts of the body and reconstruct that. And so we will, after we get rid of disease, whether it's benign tumors or cancers, we'll do different types of tissue from different parts of the body to reconstruct what we've taken away as surgeons. And then sometimes we use artificial material. So this is the middle ear, right ear. This is the mastoid. This is that bone I was talking about. Sometimes you can use what's called hydroxyapatite, which comes in a paste. You can use that to reconstruct. So some of the challenges that we face are the more complex the surgery, then the more expertise you have or need, and that makes it harder. So imagine, for example, you look at a place like India with a massive population. Pre-pandemic, I used to try to go there every couple of years. I've done medical mission trips. India is interesting to me because there's a lot of wealth in the big cities, yet there's a lot of poverty. But if you go to rural areas, there isn't someone who's a neurotologist in a rural area. So if that person needs surgery, how do you help that person without having someone who's really, really, really specialized? And so those are the trade-offs we face as a society, not just in the US, but around the world. How I do some of these techniques is use, as I said, tissue from other parts of the body. Sometimes I'll use abdominal fat to reconstruct the skull base. Sometimes I will do these procedures as I'm trying to take care of brain fluid leaks, as I'm doing cochlear implants in patients who have ear infections. There's a lot of nuances and challenges that for my field, that's why it's a 2-year fellowship beyond otolaryngology residency in and of itself. An additional 2 years is in a fellowship. So I love reading good literature, and not only do I read old articles, and I think that Google is fine for our patients to look at. But I would tell you, for those of you that are interested in medical fields, go beyond what's on Google, go to the next level and look for peer-reviewed literature, meaning someone looked at articles, because unfortunately, as we all know, not everything on the internet is true. And so what you got to look at is, I reviewed journal articles for a journal called Otology, Neurotology. And so I will actually review articles and say, is this article good enough to get published? And I would say about 70% of the time it may not be. That I'd say, you know what, this is not a good article. And you as the scientist, as a physician, as a surgeon, need to improve the methodology on your research, because you want good literature out there. And so some of the techniques are from a doc named Ulf Merck, who's from Sweden. And we're going back now 35 years since he published his paper on some of the newer and more advanced techniques for cholesteatoma. And the world's small, right? It's very flat. So I will read papers from Japan and from Europe, from South America, from Asia, from Africa, because the more you read these in peer-reviewed journals, the better a physician you are, and you can take better care of your patients. So this is one of the publications in a journal called Laryngoscope, and it was showing how some of the new techniques, even though things are better, like what we'll do a lot of times, we'll do what's called retrospective reviews. We'll look and see, hey, how did our last 150 cases go? And you look at that and say, okay, we had a follow-up time for 4 years, and that these patients had, some of them had recurrences, some of them had problems. And the more you look at your own data, and I think as a physician, as a surgeon, looking at your own outcomes is incredibly important, because you will make mistakes. You will misdiagnose. You'll have surgeries that don't go as well as you'd like. So this is a picture of one of my youngsters, very nice young man. His parents gave me consent to take some intraoperative photos. So I make the incision for this technique, one finger breadth behind the ear. I try to avoid shaving, because for a lot of patients, the idea of shaving, especially for my females with long hair, really is bothersome to me or bothersome to them. So I avoid shaving. I also tend to say, how can I do things better now than I did 5, 6, 7 years ago? I use a lot more absorbable sutures. I use Dermabond glue on the incision, because when I do that, patients are happy that they don't have pain. They like the fact that no sutures need to be removed, especially for my kids, because I don't want to hurt a child in the clinic at all. So these are some of the steps as I go through the procedure, and this is less important for all of you. My residents and fellows that are training with me know how to do this. Now, this is an interesting tool. It came out in the 1960s. This is the newest version of it. I try to use the patient's own tissue when I can, because anytime I use something artificial, the body can reject it. And so I actually try to harvest good quality bone for the patient's own skull. I use a high-speed drill, and the high-speed drill cuts the bone up into tiny little pieces. And this is called a bone pate collector, where it collects it into that, and I can reuse that bone for reconstruction at the end of the case. And so this is a picture of the technique. It's on the right side, the ear canals flip forward. This is that canal wall that I was talking about. Facial nerves here, sigmoid sinuses here. And then with this technique, this is as I took out all the disease here. This is where the cholesteatoma is. After I take it out, unfortunately for a lot of these patients, especially by the time they come to me, because I like to do the revision cases, the cases where other doctors have tried their best and they feel like they're still struggling. And so for me, it's something that allows me to train my fellows and residents well with. At the end of the case, I'll put some artificial tissue called silastic, and I try to remove that 6 to 12 months later. After I remove that, I use that to remove scar and adhesions. I put an artificial ear bone in to repair that. So I typically go in later, 6 to 12 months. I reconstruct the eardrum with some cartilage, and then you can see an artificial ear bone right there. I'm never going to get it back to 100% their God-given hearing. I know that. But my hope is I can get as normal as possible. And then if they need to wear a hearing aid, I'll tell patients that's the next step. So last few things, and then we'll get to the video. And then Michael, what I'll do is, if you can read out any questions. I will tell you, as a physician and surgeon who's done this for 23 years now, I feel like the more I know, the less I know. This stuff is hard. There are days when I'm exhausted. We know during COVID pandemic, A lot of docs and nurses were getting burned out. It was exhausting. But I think if you go in there with humility and say, I'm here to serve my patients, I think it serves you well throughout life. I try to teach my residents and fellows to be expecting the unexpected. Assume that on these cases, as I showed you, that you could have parts of the body completely exposed, whether it's dura, the lining of the brain, sigmoid sinus, facial nerve, all those things. And that's true for all surgeries. Every surgeon needs to be ready for potential complications, for potential challenges. No different than a pilot, right? A pilot can fly from Dallas to Sydney, Australia, but he or she needs to think about, what if there's a storm that arises? What if there's an engine failure? And I think a lot of times what we do in surgery is very similar to what pilots have to do and think about. I like my residents and fellows looking at the scans, making sure that we don't make mistakes and know our flight path ahead of time based off the scans. And lastly, but arguably most important, communicate with the family, have a good rapport with them as well as with the patient. Very important. Before we get to the video, I am a big fan of culture readings. If you are ever interested in learning more, there's a book by this guy, Jim Collins. He is outstanding. He's a former Stanford MBA professor. He's written one of the best books of all time, I think, for the business world, and it's called Good to Great, where he studies a lot of companies that have been around for a long period of time. Greatness is not a function of circumstance. Greatness, it turns out, is largely a matter of conscious choice and discipline. To be great at any field, whether you're Lewis Hamilton, I'm a big F1 fan, whether you're Lewis Hamilton being a phenomenal race car driver, or you're Tom Brady, or you're a figure skater, anything requires a lot of hard work. And I can tell you, for medicine, it is grueling. It is a grind some days, but it is an amazing job. And I'm blessed to be able to do this. I'm blessed to be able to serve my patients. And so for those of you, I have a nephew who was contemplating going to medicine. And the old joke is in Indian families, everyone needs to become a doctor or go into IT or software. That's always the joke that we grew up with as kids in our families. But he ended up choosing business world. My nephew did, and I'm proud of him because he didn't want to do this. He didn't want to have such a long road. And I applaud him for learning that early, because the last thing you'd want is someone like that. He's an undergrad at Emory. I wouldn't want him going through undergrad and med school and then all of a sudden saying, oh my God, I don't like this, because that's a lot of time and effort and money wasted. All right, so this is a video. I'm going to see if I can get this to play. So I love using different types of technologies, and I use the CO2 laser a lot. This video was created by some of my former residents and fellows and a young man named Charlie Poon. And I'm going to mute this if I can. Okay. So what Charlie did, an amazing job. If you guys are ever interested, you can look at the video. It's on YouTube. It's called CI Surgeon. It stands for Cochlear Implant Surgeon. CI Surgeon channel. There's about 16 of these videos, and they show, like, this is the surgical approach, and this is cholesteatoma, and this is as I'm operating with a microscope. Now, this cholesteatoma here has started to erode the inner ear. So if I don't take it out, this is a gentleman who become deaf and dizzy. And what I've got to do is be also careful, because if I'm not careful as I take this disease out, I can cause facial nerve paralysis. And so the goal is to take care of that disease. This is all cholesteatoma there. And you can see the CO2 laser. I love the carbon dioxide laser. It helps burn the cholesteatoma away, but you have to be very careful with it, because if you're not careful, you burn that, you can damage the facial nerve and cause a facial palsy. So every tool that I use has both its pluses and minuses. Now, this is an instrument called a PRAS probe. It's really neat. What it does is it puts current in. So as I'm dissecting cholesteatoma away from the facial nerve, I want to make sure I don't cause facial paralysis. I want to make sure that I can stimulate the facial nerve and dissect. So sometimes I'll use this to dissect as I'm working. This is some fascia. This is some tissue. So fascia lines the muscles. So I'm cutting that. And then I'm using the laser to get the last little bit of cholesteatoma that's sitting right in the inner ear region. So that's what I'm doing right there. So as I take that cholesteatoma away, then I want to avoid getting into the inner ear. So I use some fascia to line that area up and prevent that cholesteatoma from coming back, and to prevent it from going to the inner ear. So this is kind of a neat thing. And so for those of you that get to go to the operating room, these are the kinds of cases if you followed a neurotologist, skull-base surgeon. And the nice thing is, I got to tell you, the majority of docs across the country that you see, majority of surgeons, and the more you can spend time with different doctors. Maybe you see a neurologist one day, maybe you see a dermatologist another day, maybe you see a neurosurgeon, a skull-base surgeon, maybe you see a hand surgeon. The more you learn and you start seeing a lot of the principles stay the same, even if the field's different from one person to the next. Michael, as I'm talking here, any questions that are popping up so far?
Yeah, we have a number of them. So
You're on mute.
just to get to the first,
Hold on a second. I'm sorry.
just to get to the first question, a student asks, how do you balance your job responsibilities with your personal life outside of work?
That's a great question. It is still a challenge. I will tell you, when I went through, so I finished undergrad in 91 at Duke, med school 95 at Duke. And then we had a period of time where surgical training in particular, Michael, was very similar to military training. And you basically, I remember when I was a resident, I did up to 120 hours in 1 week. That was the most I ever worked in my life. Don't forget, there's 168 hours in a week. So that's 48 hours that I didn't work. But it was brutal. And so I trained at a time when I think the pendulum was too far in that direction, where you felt at times that the training was almost you're being used as cheap labor, so to speak. Now the pendulum has swung in the other direction. I think there's something in the between. So every single one of my residents and fellows, I try to make sure that they're getting adequate rest, adequate sleep. I want them to go exercise. If they enjoy running, using elliptical, go to a gym class, great. I want them to do that. If they are married or have a significant other, I want them to spend time. And so having a happy and healthy employee benefits everyone. But it's not easy. I do surgery. Some of my surgeries, the longest surgery I did in the last year was 18 hours long. And so for me, I'm very blessed. My wife is amazing and she's phenomenal. She's a CPA, but she's a stay-at-home mom. But it is hard. I mean, these are challenges, and some of the fields that take a lot of hours, I think some people do better with that than others, right? And I'm not comparing myself to a Navy SEAL, but you and I know some people are meant to be Navy SEALs, and there are others that are going to be Air Force people, others that are infantrymen, others that do different fields. And I would tell you, you got to know yourself. Spend time with the different fields, get good mentors. You know, you may say, I love dermatology for a variety of reasons, because for dermatology, you may say, you know what, I like to be in clinic. I don't want to be in the operating room. I have noticed there are people that are cut for the operating room, but there are others that are scared of the operating room. And you have to know yourself and have your family or friends speak into your life as well and say, you know, hey, I think you'd be doing great at X, Y, or Z. As you rotate, for those of you, I know it sounds like the majority of the people watching undergrads. Is that right, Michael?
Yeah.
So as you go to med school, the more different rotations you can do, or even now as undergrads, go spend time on these different rotations with different docs. And then you'll start seeing and have them mentor you in terms of how they handle with their lives, because there are days when I don't do a good job, and some days I do better than others. But my hope is on the weekend, you know, especially as I'm 54, my girls are 14. I want to make sure before they're done with high school that I spend as much time with them as I can over the next few years, because that time, as we all know, is gone after that. They're off to college. Out of my two daughters, one wants to go to business, the other was interested in healthcare. Healthcare, by the way, also for that person who asked the question, is different than it used to be. Used to be there were doctors and there were nurses. Duke actually had the very first PA school in the country. It started in the 1960s, and the number of PA schools across the country has proliferated. And so now there's an in-between. There are people who want to go to healthcare, but they don't want the hours that a surgeon may have. And they decide, you know what, I want to be a PA. I don't want to have the responsibility, the liability, and I want better hours. And so PA school is shorter. It's not such a long road. So that's where you can think outside the box. I have other friends of mine who are nurse practitioners. I have other friends who are CRNAs, which are basically like anesthesiologists. CRNAs are certified registered nurse anesthetists. And so they will often work under anesthesiologists as well. So, but that's a great question. Great question.
We have a few more, but we'll try to get to as many as we can. The next one we have is, and this was back when you were talking about hearing loss, how it's
Yeah.
so prevalent. Can you detect hearing loss through solely genetic testing?
So what we're doing is in America, there's what now it's called universal newborn hearing screening, and every state in America has that, which is really cool. And I've got my current fellow is from Israel, and I've said to him because he's trying to understand the U.S. He's new to the U.S. And I said to him, a lot of people forget that the U.S. is not just one big country. In a lot of ways, if you think about it, it's a bunch of smaller countries within a big country, right? So I grew up in Texas, and Texas is very different than Rhode Island. Mississippi is different from California. And so each place is different. And so some of the things I'll notice, some states will do better than others, but now all 50 states have universal newborn hearing screening. That's true with most Western countries as well, by the way. But if you go to places like India, where you don't have the ability, you don't have the funds, that's more of an impoverished nation. They can't afford to test everyone at the time of birth. So now with universal newborn hearing screening, we typically will say if someone has hearing loss, we'll do genetic testing for that. But a lot of things that you can do, and so you and I know if we're born with certain genes that predispose us to hearing loss, that's one thing. But I would tell you things that I would recommend are as we all get older, I love my AirPods, I love my iPhone, but turn the music down when you're listening to it. The OSHA, Occupational Safety Health Administration, has done a great job with reducing the amount of hearing loss that's occurring in industrial jobs, for example. But how often do people operate a lawnmower at home and they don't wear ear protection? Or maybe they're wearing, if maybe they're doing housekeeping and using a vacuum cleaner that's loud. So we don't pay attention to our noise exposure at home as much as we should do. And I think those are the kinds of things that are important. I would tell you, most Americans by the time we're 20 probably have a small amount of hearing loss. You just have so much reserve in the cochlea of the inner ear that helps overcome that hearing loss. But definitely about the 30s, we're starting to see it. And in my age group, I actually just started wearing hearing aids last year or two. And the reason is there's data now that shows that hearing loss can contribute to dementia. So the goal is, God willing, if I start wearing hearing aids now when I'm in my 80s, maybe using my hearing aids now would reduce the risk. I have dementia in my 80s or 90s, depending on how long I have to live, of course.
All right. The next question is, can colostomas be caused or made worse by cleaning out ears with Q-tips?
Yeah, so it's a great question. You can actually cause a cholestoma by Q-tip use. Very rare, but it can happen. More commonly, what I see with Q-tip use is I'll see people who've actually caused ear infections because most people don't know that the thinnest skin in the body, their two areas are very thin. Your upper eyelid skin is really thin, and the ear canal skin. And so I've had patients who've inadvertently caused otitis externa. I've had patients who inadvertently caused a hole in the eardrum. So yes, theoretically, and not even theoretically, you can actually cause cholestoma, but that's not common. So the joke I'll tell my patients, because I do have some of my patients who use a lot of Q-tips, and I'll say, nothing smaller than your elbow in your ear. If you feel like you have wax problems, the simplest thing, as long as you don't have an active ear infection, as long as you don't have a hole in your eardrum, I tell people, use a few drops of baby oil in each ear once a week. That softens the wax. And a few drops of hydrogen peroxide. Those two things put together allows your ear. It's designed to be self-cleaning. And by using the baby oil and hydrogen peroxide, you're aiding that process.
Did you get any cases over the pandemic that related to COVID? And if so, did that virus happen to contribute in any way to the actual condition, like the chief complaint, any ear injury at all?
So it's really interesting. It's amazing how the last 3 years, all the data we accumulated about COVID, and yet all the things we don't know. I'm shocked that I did not see a lot more ear problems due to COVID. We thought about patients who had tinnitus. Was that due to COVID? Ringing in the ear, right? We had patients who had hearing loss, but it turned out I did not see a higher incidence of hearing loss, tinnitus, or ear infections. Not that being said, I do think some patients had it. But I think some of the patients were so afflicted by other problems, right? Let's say, God forbid, you had such a bad pneumonia from COVID, or you had other concerns that are occurring, right? People have had heart attacks and clots in their body, that it's very possible they had the ear issues. But I did not see any significant change at all before COVID and to after COVID. It stayed about the same.
That's interesting to know for sure.
Yeah.
Each specialty.
Yep,
All right.
that's right. So one of my colleagues, really good friend of mine, Ahmad Sedagat, he's at University of Cincinnati, great guy. He actually published a lot. He was one of the first docs to publish about the loss of smell with COVID. And so for him, since he's what's called a rhinologist, anterior skull base surgeon, he saw a lot more problems with the nose than I did with the ear.
But it's both in otolaryngology. That's the thing.
That's right. Yeah.
Yeah.
And so it's interesting, otolaryngology, as you know, Michael, it's also known as ENT. I actually don't like the term ENT because I'll tell people, he and I, even though we're both quote unquote otolaryngologists or ENT doctors, I call myself a neurotologist, skull base surgeon. He calls himself a rhinologist, a sinus surgeon. Our fields overlap just a little bit. It's so funny how super specialized we each are, but because we're large academic centers, we're so super specialized that I don't necessarily see the same patients he does. He and I see very different patients. But it also shows you, if you look at the head and neck anatomy, how complex the whole head and neck is, right? You have everything from oral surgeons and dentists. You have thyroid specialists, endocrine specialists. You have ophthalmologists. You have neurosurgeons that take care of the brain and the spine, head and neck cancer surgeons. And then you have a neurotologist like myself. And it's amazing how complex all this stuff is.
Yeah. Just a quick tangent question. To what you mentioned about being so specialized, I see specialties like pediatric endocrinology or pediatric rheumatology. Like you'll see them in like taking patients from different counties, different states. They're that rare. What's the case for you, like with neurotology?
Same with me. So in this country, there's only 500 neurotologists. So not a boatload in a country of 330 million.
Yeah.
So I will see a lot of patients. So even though, I'll be moving as a March to Pennsylvania, when I was at University of Cincinnati Children's, I had patients from all over the region around the country, because you could be in small town West Virginia. There's not a neurotologist in small town West Virginia. You need a neurotologist, skull base surgeon at large academic centers or in big metropolitan areas. So if you're in New York City and Manhattan, there's a bunch of neurotologists there, right? Because that's a massive population density. But if you go to if you're in Montana, I don't know if there's a single neurotologist in Montana. There may be, but there may not be also. I don't know for sure. So it really depends on where you are in this country.
Yeah. Yeah. Demographics does play a big role.
Yeah.
We can wrap it up with.
Go ahead. I was going to
ahead.
say to you, this is really fascinating. Years ago, I was at a meeting in Sydney, Australia, and they were talking about hearing loss, the worldwide problem of hearing loss, because it's not just in the US. I mean, this is a massive problem around the world. What they said was, if you look at the continent of Africa, okay, and let's exclude South Africa for a second, and this goes back a decade ago since I was at that meeting, the person that was speaking said, there are more neurotologists on the island of Manhattan than there are on the entire continent of Africa, if you exclude South Africa. That is amazing to me, right? That the entire continent of Africa, which is a massive population. And so what we've got to figure out is we've got to think outside the box. So for example, if I said to all of you as one of the take-home messages, every one of you get your hearing checked every 1 to 2 years for the rest of your life, just like you're supposed to see your dentist every 6 months. You're supposed to get your eyes checked once a year. You're supposed to see your family doctor every 1 to 2 years, right? Now, to each his own, right? Some people may do that regularly, some people don't. I tend to be a guy who believes in preventative care, that the more you find out things on the front end, the less challenging you are to take care of stuff on the back end. So what about apps? So if you go on your iPhone or your smartphone, there are actually hearing screening apps available now. And so I think that's a good way to start, because we don't have enough neurotologists, enough audiologists to meet the demand, let alone in the US and especially in Africa. But these smartphones are amazing in saying, okay, you passed the basic hearing test, you're probably okay, but let's repeat that every 6 months or every year. And these apps, some of them are free. Maybe that's a good way to get started. So for those of you that are interested, as you're listening to this tonight, check out your iPhone and your smartphone and say, hey, let's look at some of these apps and I want to check my hearing. And that's a good way, low cost way to get started, to do it in the comfort of your own home.
Those are some very, very insightful points. And that one statistic about Africa compared to Manhattan, the distribution there, it's crazy. And we
It is
see
amazing, isn't it?
Yeah, we see so many international physicians trying to come over to the US, and even like we mentioned, even then we still are lacking physicians in the US. How much more in those other continents?
Oh my gosh. So the numbers you may know, Michael, is, and I don't know how accurate this is or isn't, but even if it's off by a factor, it's still concerning. I think by the year 2030 to 2035, we're something like 6 million healthcare workers short in America, something like that. Okay. Out of those, I don't know, maybe 1 million are medical assistants, 2 million are nurses. I don't remember the exact numbers. Okay. Maybe 500,000 PA short, something like 250,000 doctors short by the year 2035, 250,000. And then in terms of otolaryngologists, I think we'll be 1,500 otolaryngologists short by the year 2035. And that, as you said, there are a lot of docs who are coming. You know, my dad's a psychiatrist. He doesn't practice anymore, but he came from India and was a foreign medical graduate. And so there are a lot of docs I know from Egypt, a lot of docs who I know from South Africa, India. We see a lot of nurses from the Philippines. So on the one hand, that's wonderful that they're coming here to work. But like you said, you're absolutely right. What happens to their countries that they've left? If there's a brain drain and they've left their nations, that makes it tougher for the local populations to get health care.
Yeah, it is a big dilemma. And sorry to be raising up all these tangential questions, but this just reminded me. I remember hearing this maybe a year or two ago, that they're starting to open up more residency spots.
Yes.
And I'm seeing some more medical schools. I'm in Texas. I saw UT Tyler School of Medicine pop up just recently. But
where are you located in Texas?
I'm on the west side of Texas, in Midland.
Where? Midland. I grew up in Wichita Falls.
Oh, really? Wow.
Yeah.
Small world. It is a
small world. Yeah. So the problem is, you're right. We are. So for example, at Lehigh Valley Health Network, we just opened up a brand new residency, right? So right now we're just going to train one resident a year. But the problem, as you can see, is if by the year 2035 we're 1,500 otolaryngologists short, we're not going to be able to train them fast enough, right? That even if you added more residencies, this is the challenge. And I think this is where innovation has to come about. I actually think the smarter thing is, so you and I are talking via Zoom. I love telehealth because I think this idea of America's made of 50 different countries, so to speak, right? 50 states. As I work in Ohio, and I've got an Ohio license, I've got a Kentucky license as well. I had to apply brand new to Pennsylvania. It was a long, laborious process. It's time consuming and expensive. Well, during COVID, a lot of states cut down on the bureaucracy and red tape because they knew they needed doctors. So I will tell you, my amount of telehealth that I did just went through the roof, because wouldn't you as a patient be in the comfort of your own home? You're worried about coming to a doctor's office in the midst of COVID. And I think that's how you think outside the box. You know, even developing nations like India, there's so many people that have smartphones. So if we're willing to look at different options and say, you know, why can't I as a doctor see a patient who's in Africa from here? I don't have to travel anywhere. Now, if they need surgery, that's a different issue. But if they have hearing loss, they don't have a cholesteatoma, and I said, oh, I think all you need is hearing aids, that's a great way to help them. And hopefully they can find someone locally with the hearing aid stuff. I think that's how you think outside the box, and you got to be innovative and think about different solutions, because I think what we're doing now is not going to be working.
Mm-hmm. Yeah, a lot of dilemmas to think of. It's not one-dimensional for sure. There's a lot of dimensions to it. All right, well, maybe we can just cover 2 more questions and we'll wrap up this session.
That sounds great.
The next one I see here is about going back to residency. The student's asking around how much would a resident make at the time that they start?
Yeah. So the salary starts usually about 50,000, depending on where you are in the country. So 50,000, you and I know, goes a lot farther in. I did my fellowship at University of Iowa, where the cost of living is very low in Iowa City, and I love Iowa City. It's a wonderful, wonderful town. But prior to that, I lived in the Bay Area. I lived in Palo Alto. 50,000 does not go far in Palo Alto, California, right? So it really depends. And those are the things when you apply for residency, you've got to ask those questions because, some of my, one of my good friends from residency, he came in, his wife was pregnant and he already had one child. Well, that's a much more challenging cost of living issue for him with a wife and two kids, than if it's a single person. And so those are the kinds of things that you have to look at your own life and say, what can I afford? I'm also saddened by the amount of debt I'm seeing with our current medical students. And I think it's not right. We're having our undergrad students with too much debt, med students. One of my residents, she and her husband, he was an anesthesiologist. She finished otolaryngology residency. She's now practicing elsewhere in the country. She and her husband had $500,000 of debt put together. And I think that is just a massive mountain to climb because on top of that, you're starting to, after she graduated, then she and her husband wanted to start a family. So now they're thinking about, okay, I've got to get a house. That's got a mortgage. So these are the kinds of challenges that I think we need to decide as a society. And I think the cost of education is just too high. What if we did more combined MD, BS programs, right? Instead of 8 years, make it 6 years. And I think those are the kinds of things that you say. So I've said to my daughters, when they enter high school, I'd like for them to do more AP placement classes because if they can still then do just 3 years of undergrad, rather than 4 years, that'll save on costs for them for college as well.
Absolutely. And then our last question is, during medical school, did you consider any other specialties?
I did. It's hard. I love a lot of medicine. It is, you enjoy your field when there's so many different aspects. Like I'm fascinated by orthopedic surgery, fascinated by internal medicine. But I knew at a young age, in fact, the funniest thing is when I was in high school, or even younger, I remember wanting to be a cardiac surgeon. That was my first draw. And so when I got to Duke, David Sabiston was the first person in the world in the 1960s, by the way, is the first person in the world to do the bypass grafting. He did that in 1961 or something. And so he's a legendary guy, innovative guy. But I knew also as time went on, cardiac surgery is a brutal field. So someone asked earlier about a work-life balance. And for cardiac surgeons, it's much harder because your time's not your own. If someone has an emergency at 2 a.m. and you have to go do a cardiac surgery, you take care of that patient. And so that's challenging. So I knew as time went on that as much as I enjoy working hard, I knew that field would be harder for me to have work-life balance. So, where I am today is completely a very circuitous pattern of how I got here. Like I would never, as a kid, thought to myself, "Ooh, I want to be a neurotologist." It's such a subspecialized field that it's only because I had great mentors along the way. I think things like cochlear implants are an amazing piece of technology. Those are the things that really enamored me as time has gone on.
Yeah, honestly, I haven't heard of neurotology until this very session. I'm sure a lot of students can relate, so it's great to get the exposure. And we're very,
Yeah.
very glad that you could get this all together. This was such a wonderful session. Me personally, I gained a lot of insight, and I'm sure a lot of students listening in would say the very same. I do have some reminders, though, for some students who would like to earn credit for their attendance today. So for those of you who are seeking to earn credit for your attendance, we have a quiz. That quiz is now posted in the chat, the same chat that y'all posted your questions in. Feel free to hop on that quiz. It's a Google form, 10 questions. 6 out of 10 are needed or more to pass. And like I said, it's in the chat box. It's also on our virtual shouting page. We have a Monday and Thursday quiz on our virtual shouting page. Click the Monday quiz. And the deadline for that quiz will be this Sunday, February 12th at 11:59 p.m. Central Standard Time. Once you pass that quiz, you'll receive a certificate. That certificate will be sent to the email inbox of the address that you list. We recommend a personal Gmail, Yahoo, or other address, since those don't filter out things in spam. Although with that said, please do check your spam folders in case you don't see it in your inbox. In case you don't see it in both, feel free to send us an email. Again, our email is community.h4h@gmail.com. And for those who'd like to continue joining us for more sessions later this Thursday, like I said, we have Monday and Thursdays as our typical session days. We'll be joined by Doris. She's a board certified PA practicing plastic surgery in Toronto. I know there's a few pre-PA students out there, so I'm very excited for that one. Later this Thursday, again, same time, 7 p.m. Central, Thursday, February 9th. But that really is all to say. If y'all want to stay tuned with us, Instagram and our email listservs are the best ways to go about that. Like I said, feel free to reach out with any questions. But let's hear some thank yous for Dr. Samy in the chat. He took some time to get this together. I can see his enthusiasm showing through for both the specialty and sharing all this wealth of knowledge. So we really do appreciate your time, Dr. Samy. It was
My pleasure.
To hear from you.
Happy to help anytime, and congrats on what you've done. And I wish you and your students the very best.